And today we're presenting on a 2019 article by Metz et al. Called The Effects of Hydrocortisone on Autobiographical Memory Retrieval in Patients with Post-Traumatic Stress Disorder and Borderline Personality Disorder, the Role of Childhood Trauma. This article was published in the Journal of Neuropsychopharmacology, which in 2019 had an impact factor of 6.75, which places it in the top quintile of journals. The study was conducted by a team of researchers in Germany. While lead author Sophie Metz is fairly new to research, Wingenfeld and Wolf have authored a significant number of articles in the field for the past couple of decades and have really strong H indices. Our article builds on from previous research by the Wingenfeld team. In 2012, they looked at the effects of cortisol on memory retrieval in PTSD, and then in 2013, they expanded this to women with borderline personality disorder with comorbid major depressive disorder or MDD and PTSD. Part of the data used in that study we're talking about today was also published separately, looking at the natural neuroactivations in the healthy control group only.
So trauma in childhood. So distress is defined as a normal emotional response to situations or events that the victim deems shocking or horrific. So trauma can be acute or complex, and that's categorized by exposure to repeated traumas, and that can be the same or different. So examples of that include domestic family violence, neglect, or abuse. So while the definitions vary, childhood trauma is considered to take place between birth and 16 years old. Previous literature has found strong correlations between those suffering trauma in childhood and poor mental health, physical health, financial outcomes with reduced cognitive abilities. More recent research has investigated levels of cortisol through different disorders such as BPD, MDD, and PTSD, and what this means for memory systems and functions. The studies have provided contrasting findings regarding levels of cortisol. However, it's clear that exposure to trauma and chronic stress has great detriment to the autobiographical memory system. So looking at post-traumatic stress disorder. So whilst the vast majority of people who witness a trauma will be distressed for some time afterwards, the key difference between trauma and post-traumatic stress disorder has nothing to do with the severity of what was actually witnessed, but actually the length and severity of the symptoms that the victim experienced. PTSD is an anxiety-provoking disorder in which those affected experience involuntary, intrusive, and recurring memories after exposure to something traumatic. The researchers also investigated borderline personality disorder, which is considered a lifelong personality disorder and is found to be more prevalent amongst females. So diagnosis can be quite an extremely challenging process. As professionals note, BPD patients often suffer significant comorbidities, meaning that patients present severely distressed with an array of symptoms that belong to other disorders such as MDD, GAD, PTSD, or suffering AOD issues. The current findings suggest compromised stress-inducing environments, so examples of this would be child abuse, neglect, and abandonment experienced throughout development play a major role in BPD manifestation as per the gene X environment hypothesis. The HPA axis is well known for its neuroendocrine function in response to stresses. The system is compromised of the thalamus, which releases CRH, pituitary gland, which releases ACTH into the blood, and the adrenal glands located superiorly to the kidneys. The adrenal cortex is responsible for the synthesis of glucocorticoid cortisol. Acutely, the system provides the human body energy, so it may stay on high alert. However, chronic distress and activation of the HPA axis has been associated with poor mental and physical health outcomes and memory disruption. Our researchers use hydrocortisone, the synthetic version in place of endogenous cortisol based on difficulty and mixed responses on autobiographical memory throughout the previous investigations. Looking at relative literature, the use of hydrocortisone seems well suited and effective. Glucocorticoids, or GRs, belong to the steroid hormone family receptors. They're located throughout most of the body's tissues. However, relative to our researchers' investigation, they're found to be of high concentration in the prefrontal cortex and hippocampus, structures that are heavily involved in memory. Current literature notes that both the PFC and hippocampus volumes are seen to be reduced in patients suffering PTSD and BPD, and these findings were actually also noted amongst individuals that had suffered childhood traumas. Thus, there is some thought that childhood trauma may alter normal GR responsiveness through some sort of epigenetic mechanism.
Autobiographical memory, or AM, is the aspect of long-term memory for our personal experiences, combining episodic memory, semantic memory, and self-referential information. Research into the effects of cortisol on AM in BPD has had mixed findings, with some finding reduced suppression of cortisol as seen with MDD, and some finding enhanced suppression as in PTSD. At this stage, evidence points towards an interaction with depressive symptoms, not uncommon in BPD. Whichever way, AM is often impaired in BPD patients and is linked to HPA dysregulation and impaired self-concept. While this is the first neuroimaging study in the series, fMRI studies into PTSD and MDD have identified several brain regions differentially activated following exogenous cortisol activation. In depression and healthy controls, the hippocampus, which has a central role in the consolidation and retrieval of declarative memory, is highly involved. This has been attributed to upregulation of GRs in the region. Other regions that have been identified to react to cortisol are the anteromedial prefrontal cortex, the anterior and posterior cingulate cortices, and the superior and middle temporal gyri.
Okay, so over to the aims and hypotheses of the study. We've popped up the previous aims for you guys to have a look at just so you can see how it's progressed. Building on the previous literature, the present study wanted to investigate the neural correlates and use fMRI to characterize them. So it was hypothesized that the effects of hydrocortisone on brain activity during AM retrieval would differ between healthy controls and the patient groups, resulting in the following. So, number one, reduced activation of the hippocampus, PFC, ACC, PCC, and superior and middle temporal gyri in healthy controls. Secondly, an increased activation of the AM-related brain regions in patients that have PTSD and BPD after the administration of hydrocortisone treatment. And number three, that childhood trauma would correlate positively with increased activation of AM-related brain regions after the hydrocortisone treatment. All right, so on to methods. So there was 3 key phases in our test: pre, experimental, and post. So starting with the pre-test. Recruitment. The sample was recruited from a German university, from the psychiatry and psychotherapy clinic, and there was also an advertisement which offered €100 for participation, and that was targeted at outpatients and healthy controls. So our researchers employed 2 trained clinical psychologists, and they conducted interviews on the prospective participants just to confirm diagnosis that they presented with. So measures included were the borderline symptom list, the short version, and the post-traumatic stress diagnostic scale, and those measured the severity of the disorder's symptoms. They also used the childhood trauma questionnaire, and that was a 28-item self-report questionnaire. So the participants were all women, and to the right I've got an inclusion and exclusion criteria table. But just to summarize, the researchers have excluded psychological, physiological comorbidities, those with physical health conditions, and those with an fMRI contradiction. So an example of this would be a pacemaker. I think it is worth highlighting that participants that met diagnostic criteria for BPD and PTSD were not actually excluded from the study, but rather they were allocated into the BPD group. So from our understanding, that was only 4 participants. However, that was 4 from a group of 17. So that's almost 25% of the group, but we'll speak about that a little bit later. So the final sample, 78 enrolled. However, due to movement during the imaging, 5 were excluded, meaning that the total number was 73. That was 19 in the PTSD group, 17 in the BPD group, and 37 healthy controls. So moving on to the experimental phase. It was a placebo-controlled double-blind crossover design. That meant that participants received both the hydrocortisone and placebo treatment, and it was presented in randomized order. Treatment was administered orally, and it was followed by a 45-minute rest period before participants were instructed to enter the scanner, and that's where they completed their AMT. So a little bit about the AMT. The AMT is a QA task that contains 25 items, and it typically asks respondents to recall a specific memory of an event that they experienced in response to the presented word. So fMRI is actually viewed as the gold standard amongst relative literature. However, the technique does suffer some limitations, although we do feel that these limitations are suffered field-wide. So using BOLD, what you're actually looking at is changes in blood flow rather than that cellular level function. It's been noted that fMRI has subpar spatial and temporal resolution due to circulatory delays. So with consideration to the aim, fMRI did seem like the most appropriate to characterize the neural correlates. And additionally, it's a strength that there's virtually no risk to participants, meaning it can be repeated over and over again like it was in our study.
Now on to the results. The groups did not differ on any individual measures, and patient groups differed significantly based on clinical measures. All groups differed from each other on the BSL as anticipated. However, PTSD and BPD group scores did not differ significantly on the PDSR or the CTQ, suggesting a potential overlap in trauma experiences between the two groups. Still, the study was not concerned with this and looked at the patient group differences as a whole. A placebo condition was used to test areas of activation in regular AM. Bold activation was shown in the AM PFC, superior frontal gyrus, PCC, temporal lobe and hippocampus. Note, some of these areas are different to what was hypothesized, some of which are task-related. The cortisol condition was compared with the placebo condition to test H1 and H2. It was found that there were no significant differences between groups in AM after cortisol administration. The third hypothesis analysed the effects of CTQ on AM activation after cortisol administration. The results tell us that overall there was a positive correlation between CTQ scores and cortisol effects in 5 regions of the brain. VLPFC activation is associated with AM retrieval, although this was not included in the original hypothesis. The cerebellum has also been identified in executive control of memory in the past, however this has typically been found in the right instead of the left that was found in this study. Here is a statistical map looking at bold activity in the multiple regression with CTQ. So we see right lateral and left medial brain activation. Cerebellar activity is not shown in this image. So what's missing? Firstly, this study does not show how the patient groups differ in AMT score and brain activation as a result of childhood trauma. It only shows that the differences existed. As this wasn't the aim of the study, it doesn't jeopardise the paper as a whole. However, this would not have been difficult to incorporate and could have provided richer data and corroborated previous research. Second, it doesn't tell us about AMT performance. As Em mentioned, AMT scores were not collected as the test was merely used to activate AM. Problem is, without these results, it is difficult to determine how AM was activated and how this may have affected neural activation in the groups. Finally, we also don't know the strength of the correlations with CTQ. This figure is all the data put in the article. This slope shows a positive correlation, but the strength for this is not communicated.
Alright everyone, so into the discussion, let's just reflect on the researchers' predictions. So the first and second hypotheses were not supported, however the third one was supported. However, activated areas were largely different from the original prediction. So looking at some of the researchers' key findings. In reference to childhood trauma and glucocorticoids, the key finding from our researchers' investigation was the impact of childhood trauma on autobiographical memory well into adulthood, supported by other researchers within the field who have found that as trauma exposure increases, methylation of NR3C1 also increases. More recent research suggests that different experiences of trauma actually relate to differences in the CPG sites, and that can assist us to explaining differences found in methylation and the differences in mental health outcomes and disorders.
A potential confounding factor of this study is the conflicting results that have been found in previous BPD studies. In 2010, Wingenfeld and Wolf actually proposed 2 subtypes of BPD based on 2 scales. According to this model, 2 types are trauma-associated and depression-associated BPD. This is important as there was overlaps with both depression and PTSD in the BPD group. Understanding this overlap is important, especially with CPTSD rising as a competing diagnosis.
So we thought it would be interesting to show you guys this diagram. So the diagram shows PTSD symptoms, BPD symptoms, MMD, as well as where complex PTSD fits into the diagram. So while CPTSD is actually somewhat of a novel diagnosis, only recognized in the ICD-11, I think the diagram displaying the symptoms is an interesting point of consideration, particularly as it displays the 3 disorders that our researchers have investigated previously.
So circling back to the hippocampus, contrary to expectations, there was no significant decrease in activation in this area. This is despite its importance in memory and a saturation of GRs for cortisol to bind with. The authors concluded that this is because the hippocampus is less involved in AM than it is in other memory types. AM sees activation changes focused in the PFC, such as the AM PFC, critical for self-referential information. So those were some of the key discussion points, so let's wrap up with looking at implications and recommendations. This study provides increased recognition of the role that trauma has on child development and how this may have long-term implications for memory. It also shows that PFC may play a bigger role in AM than in other declarative memory systems. In terms of recommendations, to understand the neural correlates in this disorder, BPD and PTSD should probably be looked at separately as was done with a healthy control study by Fleischer. This is because the functional anatomical underpinnings of PTSD and BPD are not well understood and should be considered separately for now. In future, patient group data should be reported, as this will provide more value to the literature, as we would have the data to show not just if but how cortisol affects AM in patients with BPD and PTSD. And finally, future studies should look at memory specificity along with neuronal activations to see the effectiveness of those activations. That's it. At the end, we just have some supplementary resources and our references.
Thanks for listening.